How was yours at UWash?
It was good.
Yeah?
Mm-hmm.
30 in April treating you good?
Yes.
Able to get on the scanner and do some beam puncture?
Not yet.
Okay. You got some time. Remember, I was telling people that power injector and the beam puncture, you need 3. It needs to be over the 3 semesters. So if you're not at a site, but you are at a site that can do power injector, but if you attempt those beam punctures if you can. The rest for the clinical, make sure you fill out the clinical orientation checklist. If you didn't do that the first day, do that on eValue. Or you could print out the form and then do it, freehand, but you can do it on eValue also. 2 CEs, remember I supply under the modules, clinical modules, free CEs. Make sure they're MR specific. You could either email those or just upload them straight to Canvas. The reps, don't get too frightened by that number of 40. That's kind of what I'm shooting for. Because remember, you're trying to get 125 over the entire program. So if you don't get 40, I'm not going to take off. But that's kind of like ideal is 40. Realistic, 30. So if you're kind of hovering around 30 by the end of this 4 weeks, you're doing good. Because think, you're only 96 hours of clinic this semester. You have 192 in the fall, and then you have 256 in the spring. So you have more clinical hours in the next 2 semesters to kind of really increase those reps. But what I would hope for is at least 30 this semester, like 45 next semester, 50 your final semester. So you're not too worried about falling behind, Greg. Okay? And it's your first week. You're kind of seeing how things work. So if you're around like 5 right now, that's fine. Just try and get it up to 30 by the end of the semester, okay?
I do have a question about the reps.
Yeah.
So, what exactly counts as a rep?
Good question. So, it's different from your prereqs and like your comps and x-rays. So if you're doing the majority of the scan, and that doesn't include, that includes like getting the patient prepped on the scanner, choosing the right coil. If you have questions, the tech can help you out. Get behind the scanner, you're on the actual mouse. And then if you have to turn and ask how this slice is arranged, if they step in and actually move the mouse a little bit, that's fine. But if they're scanning the entire thing and then you just took over the mouse at the last second, that's not a rep. Just think, if you're doing the majority of the scan and you're involved in it, that's a rep. Okay? Any other questions about clinic?
I have a question about the CEs.
Yeah.
So I did mine on the ASRT website, and how let you pick a modality.
Yeah.
So I picked MR, and they were about MR, but they weren't strictly about MR.
That's fine. That's perfectly fine. Yeah. So I was going to log in. Does anybody know their login information for the ART? Because I can't. Can you come up here and log in for the other students? So when you're doing the post-primary for MR, make sure you're writing these down in your notebook too, because if the ART ever audits you, that's something that you could fax to them to verify your records. Because sometimes you need make sure to space out these procedures adequately. Don't put like a MRA head and then the next MRA head was only like 5 minutes after it. You know what I mean? Make sure you have enough time in between your reps so the ART doesn't go, that looks a little fishy. You have 10 reps within like an hour. That's not even possible. So that's the only time they'll ever audit you. All right, so once you're logged in here, you go to your post-primary, which is right here. Hit continue. And then the main things you got to be concerned about is this is your progress. And these are the reps you're going to input. So remember, you need to get at least 3 and a maximum of 5 reps for all these categories. And they add up eventually to 125. So here, Lindsay's done 3 cervical, 4 lumbar, and they haven't been verified by Rolanda, I guess, yet. But she will eventually. And once that happens, this bar will fill up, and then this bar will fill up too. And once this hits 100%, you're ready to sit for your boards. Okay, so she has 14 pending. Very good, Lindsay. And then, so to add them, and she's added them, so you need to go to your clinical experience. And then, so she's added all these, so you just select the procedure, choose whatever you're doing, say it's a brain, the time or date you performed it at, the time, who verifies it. So make sure to put in the tech that you work with and their email address, the facility, and you have to add like the address of the facility, and that's it. And then you just click Add Procedure. Okay? Is there any questions behind other than that, Tiffany? So all you need to know is the verifier. Make sure you have a good email address and the facility that you worked at and the address of the facility. That's all you need to have. Okay? But remember, this is really what you're going to be submitting to the ART, but have it written down in your notebook also, so that if they ever audit you, you can just send that. So thanks for allowing us to navigate that, Lindsay. Any other questions about clinic? All right, so let's get into our pulse sequence presentation. I feel like we're a little ahead, so even though I was out last week, we've incorporated a lot of the concepts of pulse sequences into our other lectures. So hopefully you can kind of draw on what you've learned so far to just add on to what we learned today, okay? All right, so pulse sequences, they really enable us to control the way in which the system applies pulses and gradients. So remember, the main things that we're controlling are RF pulses, whether it's an excitation pulse or an inverting pulse, and the gradients. What are our three gradients that we're going to be applying? Slice selection. What's the next one in order? Phase encoding, and then finally, frequency. Good. In this way, the image weighting and quality is determined. So we know if we have a longer TR and a long TE, we get a T2 weighted image. If we have a short TR, short TE, we get a T1 weighted image. There are many different pulse sequences available, and each is designed for a specific purpose. All right, so objectives for this lecture, we're going to be talking about the parameters for each of the common pulse sequences, the advantages and disadvantages of each pulse sequence, the uses, and the different manufacturer acronyms. So if you've worked on a GE versus a Siemens, sometimes these pulse sequences have a different acronym. So it's good to know the different manufacturers. All right, the definition of a pulse sequence is a series of RF pulses, gradient applications, and intervening time periods. So our RF pulses can either be our excitation pulse, and then with a spin echo, what's our flip angle typically for an excitation pulse? 90 degrees, because we want it on that transverse axis. And then our refocusing pulse. And what's usually the flip angle degree of a refocusing pulse? 180. We're flipping it so that we are refocusing that echo, allowing it to regrow. Our gradients, those are going to be spatially encoding our signal, right? So we have it in the slice select, the phase encoding, and the frequency encoding. First, we select a transmit bandwidth to create a slice thickness. Then our phase encoding determines the short axis of the anatomy. And then our frequency encoding direction determines the long axis of the anatomy. And that's usually, it's also called the readout gradient because that's when we're collecting the signal. Gradients can also be used to rephase and dephase spins. And you'll see this more with gradient echo pulse sequences. So we're not really using a 180 degree refocusing pulse. We're using gradients to refocus the echo. And then our time periods. These are our extrinsic parameters, things that we can change as MR technologists at the console. So this is like our TR, our TE, and TI. What do each of those stand for? Okay, what's TE?
Echo time.
And what's TI? Not interval.
Tau.
Tau. It does mean tau. Tau inversion. Yeah. So, or inversion time. So that applies to our flare and our stir pulse sequences. STIR standing for short tau inversion recovery, and FLARE standing for fluid attenuating inversion recovery. So we carefully coordinate and time sequences of events to generate a particular type of image contrast. So with that free induction decay, remember we applied that 90-degree excitation pulse. And then our signal starts to decay. It starts out very big and then it gradually gets smaller and smaller, right? That usually happens in about 10 milliseconds. Very fast. Which is too fast usually to measure any significant relaxation, right? So our pulse sequence is designed to rephase those magnetic moments at a later point in time. And that's the reason we have that 180-degree refocusing pulse, because it decays very rapidly, 10 milliseconds. So then we have that 180-degree to regrow it. So if we didn't have that 180-degree or those gradients, we really wouldn't get any tissue contrast, because the free induction decay happens so fast. All right, so here are the common pulse sequences that we're going to be talking about in the next 2 units. This unit, we're really covering everything here on the left. Spin echo. And this can be defined by spins rephased by a 180-degree rephasing pulse. That is the most important descriptor about a spin echo, that 180-degree rephasing pulse. And then gradients, on the other hand, are rephased by the gradients. So gradients can be used for spatial encoding, but they can be also used to dephase and rephase our echo. So multiple uses for our gradients. Gradients are less efficient at rephasing spins. So that 180-degree refocusing pulse within a spin echo is better for correcting multiple things. It's good for correcting chemical shift artifact, field inhomogeneities, and susceptibility artifacts. So I'm going to put over here, underneath it, so it corrects for field inhomogeneities. Chemical shift. I'll put it up here or down here. And susceptibility artifact. So that's typically why we choose a spin echo versus a gradient echo anytime we have a metal device within the patient. Because it's better at correcting for that susceptibility, metal susceptibility artifact. So if you see any MARS, if you've seen that acronym, metal artifact reduction sequence, that is usually going to be our spin echo versus a gradient echo. Our spin echo pulse sequences are considered the gold standard in that the contrast they produce is understood and predictable. So we can set an appropriate TR, we can set an appropriate TE, and we know what type of weighting we're going to get. And usually those images are good quality, and we can image most body parts. What body parts do you think we really can't image with a spin echo? Abdomen, because usually that's a breathing technique. We have to acquire these images very rapidly to catch it without breathing motion. So those are usually going to be our gradient echo pulse sequences, and like cardiac exams, where the patient has involuntary movement, and we need to capture good images very rapidly. So, however, due to relatively long scan times with proton density and T2 weighted images, these are often acquired using fast spin echo. And we'll talk about what fast spin echo is. So most of the time, when you see a spin echo pulse sequence, it's usually a fast spin echo pulse sequence. All right, so our most basic pulse sequence diagram here. So pulse sequences are illustrated using a schematic diagram that represents what each of the hardware components of the system are doing at different points in time. So here, anytime you have a rectangle coming from the horizontal line, this is our hardware component or our slice select gradient being turned on. If that line goes above your horizontal axis, that's usually the positive polarity. If it's below, usually that means it's being applied in the negative polarity. I'll just put up here positive, and then anything underneath would be considered negative. So if you have a shape or a rectangle above your horizontal axis, that's positive polarity. If you have a shape or rectangle below your horizontal, that's negative polarity. The amount of deviation from that horizontal axis indicates the amplitude of the gradient. So here we have the phase encoding gradient. At the very top we have high amplitude phase encoding gradient. Very steep phase encoding gradient has been applied. Then closer to our horizontal axis, we have low amplitude. But don't get that confused with the size of the echo that is put into K-space. So I think that was that one question that kind of confused everybody on the test a couple. So anytime we apply a steep phase encoding gradient, it's going to be usually at the top here. And if we apply a shallow phase encoding gradient, it's going to be represented by this line closer to the horizontal axis. All right, so for a spin echo, when we're talking about parameters, to get T1 weighting, so on T1 weighting, how does the fluid look? Bright or dark? Dark, good. How about fat? Right. Because fat recovers very rapidly. So our TR is going to be between 300 and 700 milliseconds, and our TE is going to be 10 to 30 milliseconds. So these are the things you need to know for when you're setting up these pulse sequences. Okay. Now they're already set within your protocol, but just think, if something kind of changed and you need to change it back, you need to know these numbers.
How much can you be out of that range and be acceptable?
I would, if you think about T1, it would be okay to go a little bit below 300. But once you go past 700, you're starting to get more T2 weighted, okay? More proton density weighted. So, but if it's a little under the 300, you're kind of okay. But you kind of should be still within those ranges. So if you see a tech and it's 701 or something, 701, they're like, okay, I'll let that fly. But if it's like 850, no, you got to change. You got to add a concatenation, usually, and then drop your TR. All right? TEs, same thing. Try and stay within those ranges, but once you start extending it past those ranges, you go from a T1 weighted to more of a proton density or a T2 weighted. Okay? And then here are your weighting parameters for a PD and a T2. Remember, we have a TR that's long, so 2,000 plus milliseconds. And then we have two separate TEs, depending on if you want a proton density versus a T2. Proton density, remember, is long, short. T2 is long, long. All right, so every illustration of a pulse sequence will always have these 5 lines. Our first line is going to be our RF. So those are our RF pulses. So our first RF pulse here, it's not written on it, but let's write it in. What's our degree? 90. And is this a refocusing or excitation? Good. What's this also called right here? Good. Read out. Because we are reading out the signal, the echo that we've produced. So let's be a little more specific about this TE. So TE is from your 90 all the way to the peak echo. That's your TE. What's our TR? 90 to what?
90.
90 to the next 90. Exactly. So your TR is always going to be longer than your TE. Everybody got that written down? Erase this. So what's happening with these spins? So remember, when we're talking about T2 dephasing, that's also spin-spin interaction, right? So we're thinking coherent versus incoherent. So coherent means everything's processing at the same point. Incoherent is when our spins start to process at different rates. So once you turn off this 90-degree excitation pulse, remember we flip it into the transverse plane here, 90 degrees, because remember our receiving coil's on that plane, we get that free induction decay. This usually takes only about how long? Free induction, very rapid. What did I say? 10 milliseconds. Very fast. So we usually can't get good image contrast between the tissues in 10 milliseconds. That's way too fast. So what we've done to regrow the signal before it's completely decayed is apply this 180-degree refocusing pulse. So see how the spins are all starting to be incoherent or processing at different rates? But then we flip those vectors 180 degrees. We flip them on their axis. So then they start to reconverge. They're all processing at different rates, and they come back together until they're coherent again. So once again, they're coherent, and that's what's going to give us our maximum signal. Okay, so then that's usually when they're coherent, all those spins in the transverse axis are coherent again. That's when we sample our echo. That's peak echo, our TE time. Okay, so here again, 90, free induction decay, 180, our signal regrows until we sample it at peak. The time from 90 to 180 is also called tau. 180 to TE is also called tau, and they should be equal. That time, tau, should be equivalent. So if it took 10 milliseconds to dephase, everything is symmetrical in pulse spin echo. It should take 10 milliseconds to rephase. Those two tau times should be equal. Sometimes you'll see it represented as 1/2 TE. So tau can also be represented as 1/2 TE because it really is divided by 2. Any questions about that? All right, so some advantages and disadvantages of our conventional spin echo. So advantages, good image quality, high signal to noise resolution, It's a very versatile pulse sequence. We can basically scan any body part. Contrast based on true T1, T2 relaxation times. So we allow those tissues to fully relax, or we allow them to fully decay. And anytime we have a true T2 weighting, it's very sensitive to pathology. Because remember, fluid is bright on T2, and usually we can detect fluid and we can see it. We can see those pathologies very well on our T2 weighted images. And then our main disadvantage of our spin echo gut is a very long pulse sequence. That's why typically we don't really do conventional, we do fast spin echoes to really speed that up. So very long scan times. Before fast spin echo was introduced, these were like 10 to 12 minute scans. So we've really reduced the amount of time we're scanning these patients. So if you had to do a brain scan, which of, like, say the T1, the T2, the flare, which are spin echo pulse sequences? Diffusion. What do you think? Is a diffusion a spin echo? Do we need to have it fast or slow to catch water diffusing very rapidly? What do you think? Fast. So think, if it's a very fast pulse sequence, it's usually our gradient echo. If it's lower in image quality, usually it's our gradient echo. What has very high signal in our brain scans? Which sequences? T2 is one, yeah. T1, flare. Those are all our spin echo pulse sequences. Okay? And then there's really only one other pulse sequence, which is our gradient echo, T2 star gradient echo. That's a gradient echo. All right, our next pulse sequence we're going to talk about is called a dual echo. This is where we're getting two images for the price of one. So this is great for when we used to do the proton density. But remember, proton density has been replaced by what? Flares replace proton density. Very good. So we don't really do this as often. But in the past, we used to be able to get two images for the price of one. What I mean by that, we utilize the time between the TE and the subsequent excitation pulse, the next excitation pulse, of the next TR period to acquire another sequence with different image contrast. So what is our parameters for a T2 weighted? Long, long, short, short. What is it again?
Long.
What, T2?
T2.
Long.
Long, long. Good. So a long TR, a long TE. So here, T2, which our fluid is bright, is associated with F. So I'm going to write underneath here the line F. And that's because we have a long TE associated with F. Our proton density is long, short. Remember that? Long TR, short TE. So this image is associated with this line right here, E. So two different TEs. One produces the short TE, or short echo time, produces a proton density. Our long echo time produces a T2 weighted image. And that's because both of these images have the same TR. So if I had to draw the TR, it's from here all the way until the next 90. So we're utilizing all this time between the first TE and the second TE. Because usually, like I said, TR is always longer than TE. And there's a little bit of time left over where you can go ahead and get another echo in that time. So we get two different images with two different image weightings with the same scan time. So this was a very popular way of getting a proton density and a T2 at the same time. Because remember, in MR, if we can save time anywhere, it's advantageous for us, right? But notice, everything else is kind of the same. So we turn on our slice select gradient every time an RF pulse gets turned on. We have a 90-degree excitation pulse. And then we have two 180-degree refocusing pulses. So you can see here how our signal starts to decay. We get our first 180, and then it regrows to our peak echo. And then it starts to decay again. And then we have another 180 degree, and it regrows. But notice how this second echo is shorter than the first. And that's going to be always the case. As you add 180 degree refocusing pulses, it's going to get smaller and smaller each time. So you can only do this a limited number of times. But the main thing to remember with a dual echo is we have the same TR for both images, but then we have two different TEs. This is going to be our short TE, and this is going to be our long TE. Any questions about dual spin echo? Two images for the price of one. Very popular back in the day. Now we don't do it because we have our flare sequence that's taken over for our proton density. So here again is another way to draw it. We have a very long TR, and anytime you have a long TR, it can't be a T1, right? So remember, that's short and short. We have a long TR, but then we have on the first echo, it's a very short TE, and notice how the echo is larger than the second echo, and then on the second TE, it's long. So this is associated with proton density. And the second is associated with T2. And then it starts all over again with your next 90-degree RF pulse. But in dual echo, we're utilizing all this downtime between our TE, first TE, and then our next 90-degree excitation pulse. So we're just maximizing our time. All right, so now our fast spin echo. So what's our scan time for fast spin echo? Do you remember that? This is part of our parameters test last unit.
The number of placement coatings times TR
Yeah.
times NSA
Yeah. All
divided by the
echo train length. Echo train length. So let me write it down here. Just to remind you. So scan time. TR times number of phase coatings times next or NSA, and all of that is divided by echo train length. Okay. So what the echo train length means is basically we're filling more lines of K-space per TR. So imagine our echo train length was 4. How much faster is our scan time? 4 times faster. Exactly, because we're dividing it by 4. So you can see how this is very advantageous for our MR text, right? A whole sequence that was conventional that used to take 10 to 12 minutes now can be knocked down to like 3 or 4 minutes, right? The only difference that's really happening between this and then our dual spin echo is that at each 180-degree phase encoding combination, so one of these 180 degrees, a different amplitude of phase encoding slope is applied to fill out a different line of K-space. So we're really not creating two images with two different image contrasts. We're just filling K-space that much faster by selecting a different phase encoding slope. Because remember, if you select the shallow phase encoding slope, we fill the center of K-space. If you select the steep phase encoding slope, we fill the periphery of K-space. So as you go down, you are selecting a different phase encoding slope. But everything else is the same. You have 180 degree to regrow the echo, and then it happens multiple times. So what's the echo train length for this diagram? How many 180s do we have?
4.
5.
I just think you guys can't count. I think you know what you're looking at. So don't count this one, remember? This is the 90. And then 1, 2, 3, 4, 5. So let's write that on top here. So this one's the 90s, just to not be confused. And then we have 5 180 degree, which equals our echo train length. So this scan is going to be 5 times faster than our conventional spin echo. So that is very beneficial to us. So if we're really creating one image, how do we determine the type of image weighting that we desire? Because we have all these different echoes, right? How do we choose the appropriate echo? Well, it's what we call the effective TOP, because we actually are going in there and picking which of these echoes we desire to give us the desired image weighting. And we'll talk about that here a little bit more. But for our parameters, T1 weighted images, our TR and effective TE is going to be a minimum, the lowest amount, and then our TR is going to be the same. But our echo train length, notice here for a T1 weighted image, can only be about 2 to 8. Because remember, we need a really short TR, so we can't add a bunch of these 180 degree refocusing pulses, because that will push our TR back. So we can only do about 2 to 8. Same for a proton density weighted image. But then look at our T2 weighted image, how many echo trains we can add on. So we can do 12 to about 30. So just be mindful of that if you have to set up a fast spin echo in clinic. So I would highlight these and then just notice what type of weighting you desire. Just remember, a T1 weighted image, you can't really have a very long echo train. All right, so this kind of describes what's really going on with that effective TE. So anytime you see on your console effective TE, that means you're selecting a fast spin echo or a turbo spin echo. Same thing, turbo and fast spin echoes mean the same thing, it's just vendor specific.
So anytime you see what?
Effective TE. Instead of just TE, if you see effective TE, you're dealing with a fast spin echo. And what's happening, so once again, our phase encoding steps are going to be changing each 180 degrees. So see here, we started off very steep. It produced a very small echo. then we came down a level. And then we slowly get to our shallow phase encoding gradient, and it produces a very large echo. So we want the large echoes to fill the center of K-space. What's the center of K-space again? Is that the resolution or is that the signal? That's the signal, right? So we want the large echoes to fill the center of K-space. So we want our effective TE to be around where the large echoes occur. So here, our effective TE occurs around the 1, 2, 3, 4, 5, the 6th echo. So that just means we need to increase the time of our effective TE to be around the 6th echo. Because we want the large echoes to fill the middle of K-space, which is going to give us our signal. We're not as concerned with the smaller echoes. We can put those in the periphery of K-space, which give us our resolution. And there's some drawbacks to that we'll talk about here in a second. But just as a reminder, a shallow gradient fills the center of K-space, and it creates a larger echo, and can also be described as a high amplitude signal. Not a high amplitude gradient, a high amplitude signal. A steep gradient or a steep phase encoding gradient will produce a low amplitude signal.
So you say you want the fast echo to be around the large echoes?
You want the large echoes of your fast spin echo to be in the middle of K-space, because that's where you get all your signal. So this kind of gives you a definition of what effective TE is, kind of clarify that again. So effective TE, so we have echoes that are generated at different TEs, because we have all those 180-degree refocusing pulses. So, and therefore data is collected from each of those echoes, and then we have variable image weighting. So then how do we determine what type of image weighting we want? We actually don't select a TE, we select an effective TE, and that means the TE at which we wish to effectively weight the image. So if we have a low effective TE, typically we're going to get like a proton density looking image. But if we have a longer echo train length, where we have an effective TE that's longer, we're going to get a T2 weighted image. Okay? So we can control the type of weighting by controlling the effective TE. And the effective TE always centers around the larger echoes. So for example, down here, if the effective TE is 100, the shallowest phase encoding steps are performed on echoes occurring at 100. Because remember, our shallow phase encoding steps will produce our highest signal. So if we desire an image contrast that needs 100 milliseconds for an effective echo time, at 100 milliseconds we apply a shallow gradient compared to a steep or a medium gradient. Okay, because that's going to fill the center of K-space. Main things you really need to take away is, on the register they're going to ask, do you select an echo time for a fast spin echo or an effective echo time for a fast spin echo? And make sure you say effective echo time, because you have multiple echoes to choose from. So when you scan using a fast spin echo versus a spin echo, you get a little bit of variation in tissue contrast. So usually fat remains bright on T2 weighted fast spin echo pulse sequences due to the multiple RF pulses. And this reduces the effect of spin-spin interactions, that T2 spin-spin interactions in fat. And that's called J coupling. So J coupling basically just means that on your T2 weighted images, where fat you should be a little bit darker, it still appears bright. Our fluid is still bright, but then our fat is also still bright. That's why I say never go to the fat when you're trying to identify whether it's a T1 versus a T2. Because you have, when it's a fast spin echo, our fat's also bright. T1 is bright. So always go to the fluid. So on these two images, you have a T1 because the CSF around the spinal cord is dark. But here, the fat is bright. And then on your T2, fluid around the spinal cord is bright, but then also your fat, your subcutaneous fat is also bright. Not as bright, but it is still bright. So please, 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 when you're identifying what type of weighting, go to the fluid. And then muscle appears darker on fast spin echo compared to spin echo due to the repeated 180-degree refocusing pulses. So we have muscle back here, and it's going to appear darker on your T2. Here's your T1 muscle, your T2, darker. A downside to fast spin echo, it really reduces our scan time, but sometimes you get blurring with fast spin echo pulse sequences. And that's really detrimental if we're trying to see a very small tear, say in the meniscus. So here we have a conventional spin echo where we can see a tear in the posterior horn of the meniscus of the knee. You see that little signal intensity right there, splitting that meniscus? Here, we get a little bit of blurring. And that's because when we're using long echo trains, like 20 to 30, like in a T2 weighted image, the late echoes have very low signal amplitude, and that's usually contributing to the resolution. So if we go back to this right here, so these longer echoes are producing smaller and smaller lower amplitude signal, and then those usually fill the resolution areas. So see how there's very little signal amplitude up here? So when you have a very long echo train length, you get what we call blurring on our image. So see how it kind of blurs out that signal intensity? You can't see it as well. So here, conventional spin echo. On the right, we have our fast spin echo, and we might miss that slight tear in the posterior horn of the meniscus. So that's why the radiologists are very specific about their parameters when it comes to echo train length on MSK imaging. Some advantages. Scan time is greatly reduced. High resolution matrix and multiple necks can be used because our scan time has been reduced. So we're really improving our signal and our resolution. So we get great image quality. And sometimes we increase the T2 information. Because remember, as we increase our echo train length, we can really only get T2 weighted images. You can't really add that many echoes to a T1 weighted image. Some disadvantages of a fast spin echo, sometimes we get flow and motion artifacts. It's incompatible with some imaging options. Fat is going to be bright on T2 weighted images. So sometimes we have to use fat sat to compensate. And that adds SAR to our patient. So we heat up our patients a little bit more when we're doing our fast spin echo. Because think about it. Remember, anytime we're adding an RF pulse, we're putting energy into the patient. So think about all those 180-degree refocusing pulses. That's just adding more and more energy into the patient. So we're really heating them up. You can get image blurring, and then that increased SAR that I was talking about. All right, finally, inversion recovery. So we've talked about this in the past. So these are usually used to suppress signal from certain tissues in conjunction with T2 weighting, so that water and pathology return high signal. What are our two main inversion recovery pulse sequences?
Stirs and flares.
Stirs and flare. What does it stand for? What does it stand for again?
Short tau inversion recovery.
Good. And then flare. What's flare stand for again? Good. Fluid attenuating. So a flare would be used in a brain to nullify CSF fluid, so we can see those white matter lesions better. Stirs are typically used with MSK imaging to nullify fat, so that we can see pathology even better. So if there's a small stress fracture in the knee, we're able to see it a lot better, that we're able to saturate that bone fat marrow. So here are your parameters. So with a stir, we have a short tau, so our TI is going to be very short, about 150 to 175 milliseconds. And then everything else is going to be like a T2 weighted image. We have a longer TE, we have a longer TR, and we have a long echo train length. So that's why that's T2 weighted. And then a flare, just notice the difference between your TI times here. Your flare is going to be a lot longer TI time because water recovers a lot slower than fat. So we're trying to nullify fluid or water, so our TI time is going to be a lot longer. So 1700 to 2200 milliseconds for a flare inversion time. And then everything else, once again, is going to be very T2 weighted. Long TE, long TR, and a long echo train length. Okay, so now going over to your illustration of the pulse sequence diagram, we're now starting with a 180-degree refocusing pulse. But it's not even called a refocusing pulse, it's called a what? Inversion pulse. So just be mindful. Highlight these. We start with a 180-degree inversion pulse. Then we have a 90-degree excitation pulse. Then we have our 180 refocusing pulse. So we have two different 180s. The first one is an inversion. The second one is a refocusing. The only difference here is, so if I basically started the pulse sequence right here, what does it look like? So if I erased this entire section right here, if I just erased everything right here, what do we have? Spin echo, right? Doesn't this look the exact same as our spin echo? And that's what's going on. The only difference is that 180-degree inversion pulse. Your inversion time is from your 180 to your 90 excitation pulse. So this inversion time over here is E. Everything else within this illustration is the same as a spin echo pulse sequence. So this is what's happening with that inverting pulse. Here's B sub 0. So all our hydrogen spins are aligning with B sub 0. We create a net magnetic vector that aligns with the longitudinal axis. We apply 180, so it flips it into, is that full or partial saturation? Full. Partial saturation is past 90, remember that? We flip it 180, and then we watch all those tissues recover from this point. Fat recovers quickly. Water recovers very slowly. So if I had to draw them, let me draw those. So fat from this point recovers very quickly. Can you see that? It's not the best. Water from this point will recover very slow. So this is why fat for our stir, our inversion time is a lot shorter, that 150 to 170. Compared to water, we're waiting it to cross that transverse line, and that usually takes about 1700 to 2200 milliseconds. Be careful with this one because your TR in the past has always been 90 to 90, right? In your inversion recovery pulse sequence, your TRs from your inversion pulse to the next inversion pulse. So that's different. Your TR is different. So highlight that. Your TR is from 180 inversion pulse to the next 180 inversion pulse. Here it says tau, but I'm going to be a little more specific. This is your TI, inversion time, from your 180 inversion pulse to your 90-degree excitation pulse. And then everything else is the same. You have your free induction decay, you have your 180-degree refocusing pulse, and then it regrows to peak echo time. This is just a reminder for that null point equation. So to get the null point of fat versus fluid, all you have to do is take 0.69 times the T1 relaxation time of that tissue. So whatever the T1 relaxation time of fat is, times 0.69, that's the null point. The point it crosses your transverse axis. Because that's when we're going to start the pulse sequence and flip it back into full saturation. So just remember that equation, 0.69 times T1 relaxation time of either fat or water. So these stir pulse sequences and flare pulse sequences, they're used in... We're not using spin echo, we're going to be using fast spin echo. So here I showed, really we only use one of these 180 degrees, but what's really happening is we're going to be using multiple of those 180s. Because it's a very long sequence, so to speed it up, we just utilize our fast spin echo. So here's our short tau inversion recovery. Remember, we are setting a TI that's very short because we're trying to null fat and see how fat recovers a lot faster. Once it gets up to that transverse line, that's when you start the pulse sequence. And now, if we look at this image, all our fat tissue, either subcutaneous or within the fatty marrow of the bone, are completely dark. So we can see any type of pathology or fluid a lot better. And look how homogeneous this fat suppression is. Way better than just a normal fat set. So if you're having issues with your fat set, for some reason it's not working appropriately, make sure to run a stir sequence to make up for it. Okay? Because the radiologist can complain if the fat's not saturating appropriately. So if it's not working for some reason, maybe this patient doesn't have much fat within their body, and it won't saturate out the subcutaneous tissue. Use a stir sequence instead. Here again, this is what's happening. We have a 180 inversion pulse, flips it completely on its head, full saturation. That tissue, fat, recovers. We select the TI time that's short, and then we start our pulse sequence. So once again, we apply, once it's hit this transverse axis, it gets flipped 90 degrees back into the 180, fully saturated again. So that's why we get no signal from fat. Here's another stir image right here. This is coronal knee image. And then the only difference for flare is now our TI time is a lot longer because we're trying to nullify. Here's a flare image down here where our ventricles are completely dark. And if we have one of those little white matter lesions, we're going to see it a lot better. So the last slide here. So with STIR imaging, it's great for MSK because it nulls fatty bone marrow, so lesions and bone bruises are seen more clearly. It has a very uniform fat suppression. The only real limitation with STIR is it should not be used in conjunction with contrast enhancement. So once you inject contrast, never run a STIR post-contrast because it might actually nullify the signal from the lesion too. Because lesions usually recover very similar to fat. FLAIR, this is used in brain and spine imaging to see paraventricular and cord lesions, like MS lesions, MS plaques, meningitis. There are no limitations with FLAIR, so you can run a FLAIR sequence post-gadolinium. Any questions? So on Wednesday, we'll have a review lecture, and we'll have a test on Sunday. So this unit really kind of is a review. The only real new thing I incorporated was the effective TE. We've talked about full sequences before, and parameters and image weighting. So that's kind of why I introduced them back then, so that you have a better understanding of them. So you see how it's all kind of coming together? It's a lot. It's slowly coming together. Any questions?